This video is going to focus on adrenergic receptors and its associated pharmacology. There are four main adrenergic receptors: alpha 1, alpha 2, beta 1, and beta 2. And I'm going to describe them in a bit more detail before moving on to the pharmacology and their physiological concepts. So the first receptor is alpha 1. Alpha 1 receptor is primarily expressed on smooth muscle cells of the vascular system. They work through a GQ, G protein coupled receptor. When an agonist binds or a ligand binds to this receptor, you get an increase in phospholipase C, an increase in IP3 production and DAG production, which ultimately causes an increase in intracellular calcium. This causes an increase in the frequency and force of contractions through myosin, troponin, myosin, and actin interactions. So when the alpha 2 receptors are activated, you're going to get actually two different effects depending on the cell in which the signal transduction pathway is occurring. But generally, the upstream part of this signal transduction pathway is the same. So when you get activation through a ligand binding to the alpha 2 receptor, that is coupled to the inhibitory G protein coupled receptor. That's going to inhibit the activation of adenylyl cyclase, therefore lowering the levels of cyclic AMP. And that's going to have two consequences depending on the cell that you're in. In the CNS or in neural cells, you're going to get a decrease in intracellular calcium. However, in smooth muscle cells, namely the vascular smooth muscle cells and normal abdominal or gut smooth muscle cells, you're also going to get a decrease in protein kinase A. And that's actually going to inhibit the phosphorylation of myosin light chain kinase. And so because you're actually decreasing the phosphorylation of that protein, you're actually decreasing its inhibition, therefore increasing myosin light chain kinase that's unphosphorylated, which is actually going to activate actin. So this is going to have an activation of actin. And therefore, you're going to get increased contraction of those specific smooth muscle cells. I also want to point out that the depression of the CNS as a result of alpha 2 activation can cause hypotension because of a negative feedback mechanism in the central nervous system. Beta 1 receptors are primarily expressed on cardiac myocytes, as I've drawn here. They work through a G protein coupled receptor, which is stimulatory, which causes an increase in cyclic AMP, which causes an increase in phosphokinase A. This increase in phosphokinase A also triggers an increase in intracellular calcium concentration, which, as I said before, increases both the contraction rate and the contraction force of cardiac myocytes. The next receptor is the beta 2 receptor. This receptor works through a similar mechanism to beta 1. However, the signal transduction events that happen after stimulation of the G protein coupled receptor is different, and that plays into its different function. So beta 2 receptors are expressed on quite a few different cells. One's going to be the bronchial smooth muscle cells, as well as the normal gut smooth muscle cells and the endothelial smooth muscle cells or vascular smooth muscle cells, as well as to a lesser extent cardiac myocytes. And although you still get an increase in cyclic AMP as a result of the activation of the B2 receptor, you get a phosphorylation of myosin light chain kinase. And when that is phosphorylated, it actually inhibits contraction. So this leads to an inhibition of contraction, which leads to dilation. So that brings us to our associated pharmacology. And there are three different types of pharmacologic agents that I'm going to talk about. The first is catecholamines, the second is agonists, and then the third is antagonists. So catecholamines are mostly agonistic, and they have dose-dependent effects on these different receptors due to their selectivity. So for the alpha ones, the catecholamine of interest is mostly norepinephrine. Now, norepinephrine is going to be a catecholamine agonist of the alpha-1 receptor, which is going to cause the vasoconstrictive effects that I alluded to before. Additionally, high-dose epinephrine is going to act on alpha-1 receptors, but to a lesser extent than norepinephrine. And then even to a lesser extent, high-dose dopamine will also activate alpha-1 receptors. Moving down, norepinephrine again and low-dose epinephrine are going to be agonists of beta-1 receptors, and so because they are sympathetic mimetics, they're going to cause an increase in heart contractility as well as an increase in heart rate, as well as low-dose dopamine. And then high-dose epinephrine, paradoxically, is going to cause bronchodilation due to its binding to beta-2 receptors. Next, I'm going to go over the agonists. So the main agonists of the alpha-1 receptors are what's known as vasopressors. So they, as the name implies, they press on the vasculature. So they're going to be alpha-1 agonists. The first main non-catecholamine vasopressor is phenylephrine. Moving down, the agonists of beta-1 are going to be dobutamine and isoproterenol. And then to a lesser extent, isoproterenol will also have mild binding to beta-2. So it can cause both increase in heart contractility and bronchodilation, but it is more specific for beta-1. Additionally, albuterol is going to be an agonist to beta-2 receptors causing bronchodilation, and that's why it's in inhalers, especially rescue inhalers for people that have asthma. Now, moving on to the antagonists, these are much more robust, and then these are usually used to treat hypertension as well as cardiac arrhythmias. So there's two classes of antagonists. Those are going to be the non-selective antagonists as well as the selective antagonists. And so I'll go into those in a bit more detail. So phenoxybenzamine and phentolamine are going to be non-selective alpha-adrenergic antagonists. And so they act on both alpha-1 and alpha-2 receptors. However, the zosins, as in prazosin, terazosin, and doxazosin, are alpha-1 specific. Therefore, they are antihypertensive medications that will inhibit the vasoconstrictive events that transpire after the activation of alpha-1. So they block that receptor, therefore lowering blood pressure. Moving to the beta-adrenergic antagonists, we have also, again, both non-selective and selective beta antagonists. And so listed here on the left are going to be a list of all of the non-specific beta antagonists. And they have a couple side effects as a result of being non-selective, specifically in their beta-2 antagonistic properties can cause bronchospasm because basically you're inhibiting the dilation of the bronchi, which, a double negative basically says that you're going to have increased bronchoconstriction. One interesting note about the non-selective beta-adrenergic antagonists is that nadolol is going to have a high half-life or a very long half-life, which means it's going to last for a lot longer. So it's a longer acting medication. But over here on the right, bisoprolol, atenolol, and metoprolol are going to be beta-1 specific antagonists. And so a lot of these are what are referred to as the selective beta blockers, and they could be prescribed for a variety of reasons, but one of the main reasons is in the treatment of arrhythmias, or when the heart is pumping too fast or too quick. And so these can be given to lower the heart rate and lower contractility of the heart. So hopefully this gives you a good overview of the adrenergic receptors as well as their associated pharmacology.